Welcome to Grand Rounds today. Today I have the pleasure of reintroducing Dr. Michael Victoroff. Dr. Victoroff is a family practitioner, and he is also a clinical professor in the Department of Family Medicine at the University of Colorado, and also a risk management consultant for COPIC. He actually has joined us for Grand Rounds previously, and I believe it was in April, provided us with a really excellent Grand Rounds on the response to the active shooter. And he kindly has accepted our invitation today to provide us with a roadmap for the short route to Telecare. And please join me in welcoming Dr. Michael Victoroff.
Thanks a lot. As you know, some of you know, my assignment at COPIC, for the most part, is health information technology. I have spent most of my career in HIT ethics and regulation and law and the technology, and I spend a fair amount of my time at COPIC in the sort of legal defense business, looking at electronic health records. But as you can imagine, about 2 years ago, a little thing called COVID happened, and there was a sharp inflection in interest in telemedicine. And there were some weeks when I did 5 or 6 seminars on telemedicine technology, because that was what we were doing. And I'll show you a graph. I have a slide that shows we're still doing it. So I've always been interested in telemedicine as a possibility. This is a wonderful cover of a magazine that I found years ago. My dad was a ham radio operator, so we had these radio magazines around the house when I was little. And this is one that shows the date on this, amazingly, 1924. It shows a doctor on TV apparently doing some sort of an exam on a bunch of people in a house over the radio, with video, obviously. And the hysterical thing about this cover picture is that television was actually not invented or not available until 1929. So this was science fiction in 1924. And here we are, just about 100 years later, and it's far from science fiction. This is the total reality. So that's what we're going to talk about that. I don't have any important conflicts of interest. I wish I did own stock in something, although I don't know if this week's a good week for it. This is much more important. These disclaimers, these are legal things. First of all, I'm not an attorney, and I'm not your attorney. And so you have to be very careful about all of the legal advice that I'm definitely going to be giving you, because some of it is going to need, some of the things I'm talking about with regard to telemedicine law definitely need you to confer with your actual lawyer, because it does get a little bit complicated. Also, I'm going to be mentioning dozens and dozens of products by name. You have to do that in the electronic world. There, things like Twitter and Facebook and Google and those sorts of things you have to mention by name. We're not endorsing any of those. And there are some slides I have with listing a lot of products. COPIC doesn't own stock in these things, and I don't, and we're not in any position to tell you which products are good or bad, because they change too much. It's just too complicated. But finally, most important, when I first did these talks about telemedicine, the laws were changing literally every week. I would have some days when I would have to change this seminar, the slides, between the morning and the afternoon, because every state board or licensure or the federal government, DEA, they were changing the rules almost hourly. That has slowed down considerably, but beware. I just downloaded yesterday's waiver document from the Federation of State Medical Boards, and it is different from what it was a week ago. So beware. Everything I tell you here is subject to change. The agenda is real simple and quick here. I'm going to spend almost no time talking about electronic platforms, but I'll speed over that stuff, which most people are pretty familiar with by now. Most of what I'm going to talk about has to do with the regs around licensure and the state board rules, a little bit around the liability issues concerning telehealth documentation, because that's a little bit different from what we used to talk about, electronic documentation. I'm going to spend 10 seconds on insurance and skip payment entirely. So otherwise this is basically a piece of cake. And I'm going to start with the end. Okay, so the end of this is that if you're licensed in Iowa, or if there's someone else here listening from a neighboring state, all you need to do is comply with your local state telehealth regs, and those are usually easy to find on the state board website. Pick a platform that's reasonably secure and competent, and talk to your malpractice carrier about whether you're covered for doing telemedicine in whatever your specialty or whatever you propose to do. If you're covered by COPIC, then we automatically cover telemedicine in whatever specialty we're already insuring. So that's it. That's the cake, piece of cake. Where it gets hairy is when you are practicing medicine across state lines. And of course, telehealth readily lends itself to this. And I'm going to spend a fair amount of time talking about the problems with what we call extraterritorial practice, because this does get complicated. These are some of the topics that we're going to touch. Licensure is really important in that state. There are regs that may be different from your state. Credentialing is going to be relevant if you're dealing with a facility, not just direct to patients, but, delivering services like radiology, pathology, etc. Luckily, interstate prescribing is actually simpler than interstate medical practice. And the insurance, I can talk to you about COPIC, but if you're insured with somebody else, you need to make a phone call. So here's one thing that's worth it. We just finished this year an update on our book on telehealth liability, and you can download this from the COPIC website. It is a really good primer on everything I'm going to be talking about here today. So the way we began this, 2 years ago when people went crazy about telehealth, was we considered telemedicine to be basically personal protective equipment. It was the same as gloves or a mask. And it was a way, you see my little emblem up there. I'm going to put that COVID-19 emblem on a couple of these slides. That means that some of this has to do with the declaration of the COVID-19 emergency that came from the federal government and was also extended by many of the state boards. Beware, although the federal terms of the emergency declaration are still in force, the state boards who have given waivers for licensure and that sort of thing, many of them have already expired, and I'm going to touch on that stuff. But basically, the idea was, let's protect our patients from dying by coming into our office and catching COVID. That may not be as serious a risk as it was back in 2019, but that was the impulse for the telemedicine surge. As we proceed, please don't forget, put a pin in the other electronic media. We've got email, texting, portals. We've got file sharing services. So, we still have all kinds of ways of exchanging electronic information. All of these still have the same rules, regs. There's still Hipaa, there's still security, there's privacy, there's some liability aspects to all of these. I particularly want to emphasize portals, because in my review of what's going up on portals, especially since the information blocking rule, this is not the talk on that, but many of you really want to audit the material that you're posting on your portals, because for the most part, it's terrible and may not meet even the federal Hipaa requirements now that have been enforced for more than a year. But besides these three vehicles, electronic vehicles, we still got good old telephone, which occupies a kind of gray zone between electronic and not electronic, in the world of HIPAA. I'm going to talk a little bit about telephonic telemedicine because it has some strange aspects to it. So, very quick, this is like blinding fast. If you need more details on this stuff, email me. But I'm just going to mention that in the early days of telemedicine, there was dispute over whether or not HIPAA considered it appropriate to use different sorts of applications, electronic applications. And the way this was solved for COVID-19, this still applies. The Office of Civil Rights still considers this an active rule. You can pretty much use anything, a commercial app, that comes with your EMR, a business class app, something like we're using now, like Teams, Zoom, incredibly popular. Even a consumer class application like, Skype, if anybody's still using that, FaceTime, a lot of people were still using that, and texting. Those who are just doing text only without video or audio, there's a bunch of those. Many of these are very secure. Signal, for example, are more secure than almost any email system you can get. And the only exception where the Office for Civil Rights drew the HIPAA line was on public-facing apps like social media. You would obviously be out of your mind, to conduct a telemedical practice over Facebook or TikTok or something. But every once in a while, we've had someone where that actually came up. One fetish of mine is this phrase HIPAA compliant. Or you see the vendors advertising sometimes, our stuff is HIPAA compliant. And I want to just emphasize there's no such thing as that. The person who's HIPAA compliant is you. The provider is HIPAA compliant. The software can't be compliant. It's how you use it that counts. And the Office for Civil Rights doesn't provide certificates to vendors, right? All the Office for Civil Rights does is come and look at you if there's a complaint and then fine you because, of course, you're not compliant. They'll always find a way that you're not. So don't fall into this trap of, is my system HIPAA compliant? However, we're going to talk about HIPAA just incredibly fast. During COVID-19, at the beginning of the emergency, and as of this afternoon or this morning, still the Office for Civil Rights considers this waiver of certain HIPAA rules active right now. Please be aware the HIPAA waiver for compliance over telemedical platforms is just for telehealth. There's no waiver for people inside your office, so you still have to give them the notice of privacy practices, and they have to sign the receipt of acknowledgement of notice of privacy practices, and all of that stuff. Those ceremonies for HIPAA still apply and are active in person. But you can see that the OCR was not applying penalties for telemedicine HIPAA ceremonies, and that's still true. In fact, it's still quite hard to get an electronic signature over telemedicine in some platforms. So don't worry about that for now. And in terms of hardware, again, software, I'm not going to spend any time on this. There's a million of these. If you do a web search for stuff like this, again, no endorsement, but there's lots and lots of these that are very popular and, according to my informal surveys, pretty effective and satisfying platforms for docs that want to do telemedicine. And a lot of the EMRs have done deals with these or have even incorporated them. So yeah, there's a lot of ways to do it. The hardware, that's simple. You already probably have it. In fact, if you own a cell phone, you can conduct a pretty reasonable telemedicine in some specialties over a cell phone. The issue is not really the platform, it's the bandwidth. And when you get pinched by your ability to transmit or carry a signal, That's where we see most of the issues for liability or failures of the platform. But it isn't the bandwidth you've got that makes the most difference. It's the bandwidth on the other end. The question you have to solve for some patients is, if you're out in rural Iowa someplace and your town just doesn't have any kind of decent internet, then that's got to be one of the considerations you weigh in whether or not you can effectively manage their problem. So, can they run whatever devices they need? Is your picture good enough to do whatever dermatologic diagnosis, or run listen to the heartbeat over a fetoscope, even if they have one. And you're going to need to talk about privacy. Are they in a public library, or are they in a room in their house with a bunch of kids running around? Are you going to ask them to undress as part of the visit? So you need to give a certain consideration to the patient's capabilities, and this is part of the documentation requirements in your telemedicine note. These are some of the apps for patients. They may be calling you or asking you to participate in these apps. For the most part, these are going to be operated by the very large telemedicine providers, not folks who are in private practice. These are groups like, Teladoc and MD Live that have, literally hundreds of doctors working for them with licenses in 50 states and so on. You may not come across these, although the records from these may find their way into your system. And then, kind of finishing up on hardware, hopefully you're aware that there are literally dozens of internet-ready devices that you can plug into a telemedicine session. You've seen scales that deliver the weight to your EMR. Down there is an otoscope, a sort of internet-ready otoscope that the mom can stick in their kid's ear, and you can see a pretty good picture of an eardrum. Spirometer, EKG, pacemaker monitoring, stethoscopes of all kinds, fetoscopes. And these things are incredibly useful. Again, talking about your documentation, you want to make sure that you make a note of what did you use and was it satisfactory, for diagnostic purposes. And the problem is that some of these apps and some of these devices can be a little bit buggy. And if that's the case, you're going to need to mention any barriers, shortcomings, or difficulties that you needed to overcome during the telemedicine session, especially if they interfered with your ability to deliver the quality care that you were hoping. So, okay, enough of that hardware, software. Well, I'm just going to quickly skim over the use cases for telemedicine. This is moderately amazing. You can see us back there in 2019. There was a smattering of telemedicine, mostly telestroke, teleradiology, so very specialized things. And then whammo, COVID, and there was an increase by a factor of almost 100 times in the utilization of telehealth in the early days of the epidemic. But here's what's amazing. That did not disappear. We never went back to baseline, and right now we are still, here's 2021. In 2022, it's still 30 to 40 times whatever it was 2 years ago. This is busy, interesting stuff. If you're not doing telemedicine now, someone is already offering your patients telemedicine services, whether you know it or not. So here's some old data from Epic. Epic is a big EHR vendor, but they have a lot of data. So looking at what is happening in telemedicine records in Epic, you can see it's all the same stuff that walks into a primary care practice. The numbers of visits simply just outweigh everything else. But when COPIC looks at telemedicine, especially in terms of liability and quality of care, the thing that jumps out to us are the specialties that I call, a brain in a bottle. These are specialists. What specialty Telecare has done is it's delivered secondary or tertiary level expertise to rural hospitals, rural offices, consultations. Teleradiology, that's been around forever, and it's been a wonderful service. Even at academic medical centers, telestroke is now routine. It may even be a standard of care in some places when a person comes in with a stroke. But look at all these other things, gastroenterology at a high level, transplant surgery, biophysical monitoring, neonatology, people who provide translation or signing services for folks with limited English proficiency, correctional medicine, of course. This has been tremendous advantage in terms of efficiencies for people who are difficult to reach, but with specialists, military. Telerobotics, maybe not yet so much, but yes, a little bit of it. And of course, the dominant ones here, besides radiology and pathology, are psychiatry. Over 50% now of psychiatry is happening across the United States through telemedicine. And now it's timely. I just threw this slide in, last week. We're going to be seeing abortion services delivered through telemedicine. And this is going to require an enormous amount of prudence and care and circumspection among physicians and clinics that are providing interstate abortion service. Whatever happens in your own state, I trust you to figure that out and comply. But there are many states that are very busy imposing laws and regs now about extraterritorial providers who want to deliver telemedical abortion services, or even, pregnancy counseling, contraception counseling, all that sort of stuff. The psychiatrists may even be involved. My only caution on this is we are not ready to give you any advice. This is a churning, chaotic legal environment where you're kind of on your own day to day right now to figure out what you need to know, and I advise you to use your legal advisors liberally if you're in this sphere. So here, legal and regulatory. A year ago, even 2 years ago, I was getting 4 or 5 phone calls a day about, can I do this? Can I do that? Is this legal? Those calls fell into 2 very large categories. And I want to separate those for you. You're probably aware of this now, but this was my life, over the last 2 years. Some of the calls had to do with, can I do this sort of medical clinical thing over telemedicine, and is it within a standard of care? Those are medical practice questions, liability questions. But many of the questions had to do with, will I get paid if I do this thing over telemedicine? And since they all had to do with, regs and compliance, I had to be very scrupulous in splitting the advice that COPIC would give and stick mostly in medical practice. You're going to have to talk to your compensation reimbursement specialists about payment, because all of the payers have their own ideas about what's covered, and some of those rules, even the Medicare rules that are, that's the big gorilla, are very strange still. So here I'm going to mostly just talk about healthcare quality and liability for telemedicine. So here, this is just a picture of the presidential declaration of emergency. This is just the renewal that the current president signed. President Trump was the first one to sign this back in 2019, and Biden just extended it. We're still operating under this rule. When it'll expire, who knows? We monitor this continuously. You're going to have to monitor it too. When COVID is cured and we don't have anybody getting sick from it, that's probably when the emergency will go away. So here, what do these regs do? All right, not too much on this. There are a lot of definitions of telemedicine, and in 2018, I spent some time on this slide. There were technology regulations. What the guys that invented telemedicine had their own idea what it was. The regulators got to vote, of course. Insurance companies had to define it, and the financial companies had to define it. Insurance, I mean malpractice insurers. Then we had these words like telehealth versus telemedicine and e-health. What is that? And m-health and all of this, forget it. Most of these things now have been blurred into one simple fog about it's electronic communication. I did pull out the Iowa definition for those of you in Iowa. This is as current as it can be. I didn't look this morning. But one of the really important things I want to highlight here is that unlike some states, Iowa does not consider telephone to be telemedicine. You need to be a little careful about this, especially those of you who get phone calls from people in Minnesota, Nebraska, or Florida, for that matter. Some states are beginning to consider the telephone to be a form of telemedicine, and they may ask you to have a license to take a phone call from their state. I'm going to expand that in a minute, but so far we've not seen a lawsuit. The COPIC has not seen one that I know as of last week against a practitioner that answered the phone for an established patient, that was traveling in another state. We used to do this all the time, right? Who hasn't gotten a phone call from a patient on vacation that needed a refill or, got a cough or something? I will address that several times, but the underlying rule for liability is if it's an established patient, don't abandon them. You have a duty. Pick up the phone. Try to deal with it. Do the best you can. Where it gets a little bit strange is when they're in another state and they want to talk to you over TV. And I'll talk about that in a second. But here, in general, this is just Iowa's Board of Medicine and the legislature's view of what telemedicine is inside their state. This pertains very importantly to docs who have licenses in Colorado who get phone calls from Iowa. But here, look, let me highlight again. HIPAA orphaned the telephone. You remember, fax and phone were not considered electronic under the early years of HIPAA, weirdly, and it was for, sort of empiric reasons. But now we're beginning to see sort of this dual, strange, Schrodinger's cat kind of role of the telephone. We don't consider the telephone to be the same sort of thing as televideo right now. But as I mentioned, there are some murmurings in some states about whether we should. So watch this space. This is the uncertainty principle, probably for 2022 and 2023. This is the most important slide in the whole deck, okay? Those of you who are either getting phone calls or offering services to people in other states, whatever they are, need to know, you do know, I'm sure you know, that the definition of medical practice is based on where the patient's feet are. Or, I really should say the patient's pulse. If they're lying across a state boundary, I'm not sure how they will argue this one, but basically, the physical location of the patient at the time of service. We don't care where you are, the provider. The license issue pertains to where is the patient calling from. And it gets really strange when it's out of the country. But let's just talk about U.S. states and territories. If you're talking to a provider, these rules don't apply. So like for things like teleradiology, telepathology, if your service is a consult to another licensed practitioner, then you have a licensed intermediary between you and the patient. And mostly the state boards are happy with that. They don't care about your license then. Where the license becomes relevant is when you're talking direct to a patient. What establishes a provider-patient relationship? That's a gigantic bit of law. I'm not going to go into it. We could spend an hour. But in general, if it sounds like you're giving medical advice, if you're prescribing a pill, if you're recommending a treatment or a test, pretty much consider that practice of medicine, okay? Those of you who have nursing licenses or PA licenses or some other kind of a license, psychology, you're going to need to look at your own board rules. They're mostly very parallel to boards of medicine, but there are some differences, beware. One of the nice things about interstate practice is that for 50 years, we've been prescribing medicine by phone calls to other states, and we've been able to rely on the pharmacist to tell us if it was okay. We get that phone call from Hawaii, and they said, my Lasix fell overboard. I need some more, Lasix. It's not a controlled substance. Who cares? You call the Hawaii pharmacy and you say, hey, look, I'm in Iowa. I don't have a Hawaii license, but my patient is established. Will you take a prescription? And the pharmacist was responsible for knowing the law in their state. And the pharmacist would tell you, yeah, I can do that, or no way, I'm not doing it. 500 Percocet for, it ain't happening. And you were on good legal grounds to accept the decision of the pharmacist. And usually, almost always, they would say, yeah, established patient, a drug that makes sense, fine, here we go. It did get a little problematic with controlled substances, obviously, and when you are prescribing controlled substances, I'm going to talk about what the DEA says about that in a minute. A few states do have a thing called a limited telemedicine license. I put a caution up here because this has been changing over the last few months and weeks. I'm not confident that this list is accurate now. I'm pretty sure about Arizona. I just talked to their board not too long ago, and they just passed a law last year allowing a limited telemedicine license. You don't have to get an Arizona license if you got, snowbirds that go down to Phoenix every winter. But you should always look for this. If you've got a patient calling you from another state, you might want to check and see if there's a possibility of a limited license instead of a full license. Most states, unfortunately, however, require a full license in order to deliver telemedical services into their state, period. Period. There is this thing called the Interstate Medical Licensure Compact. I'm not going to go into it very much. It is basically an application filling service that significantly expedites your application for a license in another state. But don't go signing up for 50 licenses unless you want to apply for 50 different license fees. They don't waive the fees. This isn't reciprocity. This is state licensure. There are exemptions in almost every state for an established patient where you're doing active follow-up for a current diagnosis. If the patient came to you for a knee replacement and they drove back to Kansas and now it's all red and hot, like I said, you better take that phone call. Surgical follow-up, a medication reaction, something that you're actually following, a diagnosis, you're required to maintain that relationship and, deal with it the best you can. You may simply have to say, oh my God, that sounds terrible, go to the ER. But do make a note of that telemedical contact. So there are some specific kinds of regulations you need to be aware of. Look around your neighboring states, and if you're the kind of a doc whose patients come to you from other states for services and then go home, learn about this. And then we'll talk a little bit about the waivers. Just for your entertainment, this is the list of states that currently belong to the IMLC. Iowa is a member. Missouri's not, so that's kind of an irritant, but there are other neighboring states where you can get a license if you need to, or, if you have like 100 patients in Texas, then look into that. This is a fabulously useful but slightly dangerous resource, the Federation of State Medical Boards. I just pulled this down yesterday. This was last updated yesterday. They do this every couple of weeks. I watch this thing regularly. This is their attempt, and it's very, very good. It's an attempt to monitor all of the state laws, the changing laws of 50 states and territories, including Guam, if you're into that. But I have to give you a caution. I have found discrepancies in this document between what's on the state board site or what's in the state statutes. COPIC's legal department warns everybody that some of these laws are not very well written, and it's even impossible for our legal team to figure out what they say. So you should use this. You should definitely start with this, but you should never forget to go on the state board site, or even what I do regularly. Someone calls me from Massachusetts and wants to know, what can I do there? I just call the board and make notes. That's what you have to do too. Let's see. Let's skip. Oh, Colorado. I just put Colorado there because that slide should have been hidden. So here are the extraterritorial tips, right? We call this extraterritorial practice. It's foggy. It's weird. We so far have not found a doc who has been criminally charged with a felony for practicing license without practicing medicine without a license, when it was, good faith attempt to follow up an established patient. We have had some felonies for docs that were really misbehaving, the Percocet people and the, Viagra interstate Canadian people and, some device fraud people, but, that's not you. Creating a new relationship with a patient you've never seen in person is the riskiest, but it's not impossible. We occasionally get that phone call about, I'm at Thanksgiving and my grandpa's having chest pain, would you talk to him? And of course you would do that, but you would stay on the really, really safe side of conservative when you're managing something for a person that you don't know and don't have records for. As I mentioned, there are some waivers for some patient that is under continuous care. I mentioned always take that phone call from an established patient. Don't get into the abandonment thing, but stay conservative. What you would always do. If someone says, I just have a blinding headache and a stiff neck, is that anything? You're not going to want to deal with that on TV. Bail out. Say, oh, wow, that could be serious. Go thee to a nunnery, or whatever. Here, look, Iowa Board of Medicine. For those of you who aren't in Iowa, or for people who are, if you're outside of Iowa calling into Iowa, they had a waiver up until May of this year. Iowa's permitting outside licensed doctors, if you had a bona fide license in another state, they were letting you conduct a certain amount of care inside Iowa telemedically, but that's gone now. This is your notice that if you were one of those docs practicing into Iowa without an Iowa license, don't be doing that anymore. That disappeared 2 months ago. And then I also looked up these other guys. Iowa has like 6.5 states that are neighbors. And this is actually quite interesting. I didn't know this until this morning. Illinois had a waiver still has until next week. If you're in Iowa and your patient calls from Illinois, they were letting you do telemedicine there, limited, without a license. But as of July 24th, you can't do that anymore. Kansas has currently a waiver, but it's going to be disappearing in January, at the end of this year. All the rest of these states' waivers have already expired. So, they've decided COVID's gone, it doesn't exist anymore, waiver gone, you need to get a license. Okay, I just have a couple of examples of some states that are nearby. Full license required, order rescinded. This is kind of what you see if you go on the websites of some of these states. So I'm just going to talk for 1 second about controlled substances. This is really important. When COVID came about, the DEA waived this requirement for conducting at least one in-person visit before you can give them, Percocet or Demerol or whatever it is. Adderall, that was another really biggie for the psychiatrists. This waiver is still in effect. So when you talk to that pharmacist in Massachusetts, just make it very clear, be transparent. I don't have a Massachusetts license, but I'm their psychiatrist or pediatrician, and it's an established patient. Are you able to do this? And for the most part, the pharmacist will tell you something like, well, I need to check the prescription drug monitoring program for you. You don't have a PDMP, access here for Massachusetts or Florida or California. But if I do that for you, then probably we can do this as a one-time exception, blah, blah, blah. We have those conversations. Just be sure that you check all of the boxes. So this is the website where that waiver is. This is the standards and the conditions that the DEA put on those waivers for controlled substances. It can be done, but as you know, you have very important documentation requirements, and it needs to be within the scope of your practice. It needs to be reasonable for the condition you're prescribing in terms of amount, duration, and of course, if it's medication management for substance abuse, you need to follow all the appropriate rules for documentation and surveillance. So here, about your note, COPIC is we're into malpractice, right? So we're very concerned about defending you if something goes wrong in a telemedicine encounter. And the kind of stuff that we care about are the consent, the note, and the Hipaa notices. Don't worry. The consent, some states do have a very specific consent form for telemedicine practices. I wasn't able to find anything bizarre about Iowa, but one of COPIC's advices is when you're documenting a telemedicine visit, of course you're going to say telemedicine visit conducted via whatever your platform, but also a nice note that just a mention. Patient is aware of the pros and cons and risks of the telemedicine platform. You don't have to have a signature or anything weird about that in Iowa, as far as I can tell. One real big issue is recording. We definitely do not encourage you to record anything on a telemedicine visit, except maybe the consent. That might be good, in which case you say, hey, my platform allows me to record you. There's a little red light in the corner. I'm going to turn it on now. Would you please say, yes, I agree, and then I'm going to turn it off. So that's good. But the problem with recording anything in telemedicine, and this goes to those, televideo of the melanoma exam or the kid's ear or the musculoskeletal exam for neurologic injury or workers' comp, those kind of things. It's very tempting to want to record those, because you can. But beware that when you make a recording of anything happening, quote, in your office, which telemedicine is, you need to follow the preservation and production rules for that for the next 10 years, or whatever your state law is for preserving medical record. That is a medical record. So you need to keep it HIPAA secure, and you need to deliver it if you ever get a subpoena. So, your choice. I also do want to mention that your patient is very likely recording it, whether you are or not. Because even though the little red light may not show up, they could have their cell phone right in front of the screen. And many, many patients do record visits with their doctors. In the office, 26% of patients admit that they have recorded a medical visit without telling their doctor. For telemedicine, that number, we don't know, but it's certainly higher. So other parts of your note, especially let us know that if they're in state or out of state. This has everything to do with your legal defense. So be sure you say, televideo visit on Zoom with patient in, Afghanistan, whatever. We want to know the modality, as I mentioned, and any devices that were used. Fetal heart was detected with a fetoscope the patient has in their home. We also want to know who's participating. I am using a scribe. I introduced them. They're in the back of the room. They're not speaking. Patient's mother was present, and she signed all of the consents in the office months ago. I don't know who that person is wearing the black hoodie. I asked the patient. They weren't sure either. We need to know, because theoretically these are HIPAA issues, but they also may be people who have an influence over what's going on at the patient end. So if you have a medical student or a nursing assistant, or your PA comes in, or neurologist looks over your shoulder, we make sure we have that in the record, because if the patient says, "Who was that masked man?" in your deposition, you're going to need to remember. The other final thing is, in your note, if there's something you do that's a variation from what you would have done in the office, be sure you put that down. We can't have telemedicine notes that say things like neuro intact, or muscular strength 5x5 in all limbs, or whatever, the bowel sounds are active. We can't have that stuff that we would normally just accept in a physical visit, unless you can explain how you know, because someone could easily challenge, what are you talking about muscular strength? And then you have to say, well, I had them lift the couch over their head, or 2 milk cartons in either hand, whatever it is that you did. The PT people have some wonderfully elegant ways of doing neuro and muscular and mental status exams. But you're going to have to do that. If you have the mom put her ear on the baby's abdomen and say, yeah, it's making noise, yeah, good. That's terrific, but tell us. Okay, and then the final thing I already mentioned, the Hipaa notices that used to be required, they're not for telemedicine. I mentioned recording. This is kind of interesting. Look at your neighboring states. Illinois is a two-party state. All the rest of the states around you are single-party states, including Iowa. What that means is anybody who's a party to the conversation can record it without telling the other people. So in all the other states that touch Illinois, they can record without telling you. And they are, I promise you. In Illinois, it's illegal for them not to tell you, for whatever that's worth. Patients may not know that. Okay, so malpractice. We're going to kind of finish up with malpractice. This is in flux now. Telemedicine has made medical malpractice pretty interesting. The definition of malpractice. It's used the normal standard of care. Here's something that we have not seen yet, but we have brushed against it with some telestroke and telepathology cases, malpractice cases already. Was this a situation that required you to get a telemedical consult, or to turn on the TV, or to do, to use a device? Pulse ox, for example, they had it, you didn't use it. What's wrong with you? So we are expecting to see some claims pop up for failure to use some kind of device that was readily available. Haven't seen those yet in direct-to-patient, but we have seen them begin to show up in doctor-doctor consults. Did not review the CT scan or something. Be aware also that your specialty society may have a guideline for how you conduct yourself on telemedicine. This is just some examples. This is out of date. Go look at your own. I can almost guarantee you that whatever kind of practice you have, there's probably some organization that has published a guideline for how to do it. Of course, these are only guidelines. They're not laws, but in your deposition, when you get sued, somebody is absolutely going to ask you, are you familiar with the guidelines? The same as they do for any other kind of thing. This is the issue about credentials. Those of you talking direct to patients at home, you don't care about credentials. But if you are delivering services into a facility, that is accredited by Joint Commission or state law or some other organization, you need to ask them, am I okay with this? And especially if you are a facility that has out-of-state providers, be sure that you find out with your legal counsel whether there are some hoops to go through for credentialing and privileging. So here, look, this is a summary slide. You can get these slides. I don't need to read through this again. It just summarizes kind of the stuff that I've been talking about. This is the roadmap for how to practice telemedicine. Okay, so liability, piece of cake, 2 minutes. The general philosophy about malpractice is for telemedicine is medicine. Same sort of philosophy applies. We know why you get sued now. We think you're going to get sued for the same stuff in the future. The good news is, here's an article from a couple of years ago in JAMA. Some guys reviewed all of the malpractice cases since the Big Bang, and they could not find a reported case of medical malpractice for direct-to-consumer telemedicine. Now, that's 2018. We think there are some in the pipeline, so watch this space. But we know what they're going to be for. It's the same stuff, right? You misread something. You gave the wrong advice. You didn't examine the proper body part. You didn't communicate something. You skipped a vital part of the history, or it was wrong, or you lost your signal in the middle of the exam and you couldn't get it back, and the patient somehow. We actually had one case of a patient that lost consciousness and collapsed in the middle of the telemedicine video, and the doctor had no way of getting in touch with them. That could be a fault on your part. So, same old stuff, malpractice. Also be aware that your documentation for telemedicine, the rules for documentation are exactly the same as for in-office visits, keeping in mind the difference of platform. And there will be subpoenas for these things. The talk I give about how metadata is used in every malpractice case we see. That your EMR has timestamps. That late documentation is a really big issue. That inconsistent, incongruent documentation, timestamps on different orders that show up at different times. We just had a case yesterday where the first thing the lawyer said was, you better get the metadata about that because it looks as though the provider wrote the physical exam 2 days after they saw the patient. Be aware that this stuff is a real big deal in depositions these days. And then the underwriting issues for medical malpractice. In order to give you insurance, we need to know that you have the proper license in the state where you're prescribing. Also, we need to know that your conduct is within the scope of the practice for which we've given you insurance. So if you're a doctor that's insured for dermatology and all of a sudden you're doing, medication management for controlled substances, you may run afoul of your insurer, which could be COPIC. There are some states that have special rules for malpractice, special rules for insurance companies like COPIC. And so if you do regularly deliver services across state lines, absolutely talk to your underwriter in your malpractice carrier, because there may be some considerations that we need to take into account in order to make sure you have coverage. One of the most important coverage issues is if you're not licensed in a state, then you're not insured. How can we give you insurance where you're not licensed? Okay, so I already mentioned abandonment. Which claim would you prefer? I abandoned the patient and they died, or I tried to give services the best I could, knowing that I didn't really have a license over there, but Your Honor, it was an emergency. So finally, here, this will take 25 seconds. Payment. This is the Wild West. It still is. Medicare has kind of stabilized around some rules for now, but they still were operating under COVID rules for a long time, and look for changes among all of the private and public payers as telemedicine costs get evaluated by their underwriters. Here is a useful resource. I'm not going to tell you what the rules are, but here's some resources. Medicare, the Center for Connected Health Policy follows Medicare very closely, and they have super good advice. This is just a summary slide for the Medicare rules about payment. And the only takeaway from this slide is Medicare says these are not permanent rules. This is just COVID. Oh, we're all going to go back to the stupid way it was in 2018 as soon as COVID is cured. But I have an objection to that. So I'm going to finish up with an editorial here. CMS says these are not permanent rules. I really doubt that. I don't think you're going to put the toothpaste back in the barn. Telemedicine has exploded in a fabulous degree. And I don't think Medicare or anyone is a big enough gorilla to say we're going to go back to 2018. I think we're going to live with new rules, new payment, new liabilities, and hopefully at some point better licensure than we had. But I think that CMS is wrong, that we're just going to revert. Here's why. We already are seeing telemedical visits approaching the number of in-person visits. This was an old prediction from a couple of years ago that they were going to outnumber in-person by 25. We're already very near to that, okay? All bets are off. And finally, this is my last editorial. This is Texas Medical Center. That's where I went to school long ago. And they built this thing, on the theory that the patient is going to physically locate. They wanted geographic monopoly, and the patients would come to them, and they would be doing all the hearts for miles around. But now it's very possible for Massachusetts General Hospital, Cleveland Clinic, pick your favorite, Rochester, whoever is your competitor. They are absolutely going to be offering the same services you will be offering via telemedicine. And so the rules for how we compete and even what we build and how we design healthcare systems in the future are going to be totally disrupted in the future. Okay, so I got a ton of resources for you. This is me if you need me. And I'm going to stop sharing, and for a couple of minutes I can answer questions. I don't see much in the chat yet. Here, wait a minute. Let me figure out how to stop sharing for a second. There we go. And somebody made a comment here in the chat. Sports medicine providers protected by federal law while caring for their teams during travel. That's nice. There are some other exceptions. Military doctors, VA doctors have kind of a 50-state license. So we hopefully will see more exceptions like this. But, be aware that if it's a high school team, this may not apply. I'm not sure. Any other questions? Somebody want to shout out or type? One 1,000, two 1,000. Looks like people have already escaped or are escaping the meeting room. All right. Well, you know how to reach me. Please let me know if something comes up. Thanks.